Good afternoon, and welcome to Safeguarding Patient Privacy in an Era of Ever-Increasing Digitization and Connectivity, a webinar tweet chat combo from healthsystemcio.com produced in collaboration with CHIME. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We encourage you to send in questions today, so as they occur to you, just go ahead and type them in, leave the default set to all panelists, and we'll take them later in the program. And you could download the deck by using the URL on your screen, and it's been sent out in the chat box. Just so you see how we're going to spend our time today, we're going to have a nice conversation with Will Smart, CIO at NHS England, and Sri Bharadwaj, Director of Information Services and CISO with UC Irvine Health. So let's jump right in. Let's start with you, Will. You want to give us an overview of your organization, which will need a little more information than usual, because I don't know how many of our audience are very familiar with the NHS structure and the role of NHS England and versus the trusts and all that. So if you want to just give us a brief overview of your organization and role, we'll go from there.
Okay, well, welcome everybody. I'm sitting in London. It's nearly time for me to go home, so I'm sure you will all feel my pain. My name is Will Smart. I'm a CIO for the health and social care system in England. So I am effectively the Chief Information Officer across the whole of the NHS, across the commissioning system, across the provider system, and also for social care across across the whole of England. To give you a sense of the scale, England has 57 million citizens to which we deliver healthcare. We are a socialized system, so we are funded from taxes, and healthcare is available free for all citizens at the point of care. In terms of some numbers about what we do, we spend 126 billion pounds a year on healthcare. We have 240 secondary tertiary care hospitals, 7,500 primary care practices, 106,000 doctors, 285,000 nurses, 1.3 million staff in total. And in terms of the system itself, in terms of the 2017 Commonwealth Fund survey, the National Health Service was the leading system globally in terms of safe care, affordability, equity, and care process. In terms of outcomes, we're 10th, but we showed the greatest decline in mortality amenable to healthcare, nearly 40% between 2004 and 2014. So we're a large single system. We do have some private providers and some third sector providers as well, which we can talk about a little bit later on if necessary. I think I'll leave it there. That probably is enough, but happy again if you've got any questions.
Well, let me ask you one follow-up just to get a little better idea. Can you give me some insight into the relationship or the role, sort of your role, the role of NHS England? Yeah. And I know there's NHS Improvement, right? Yeah. That's another entity that and then there's NHS Digital, and now they've created something called NHSX. So we've got these entities. Then we have the individual trusts, which is where the sort of the rubber meets the road. That's where the care is delivered. And you used to be a CIO for one of those trusts. So we have the trusts. We have different types of trusts. And then we have different levels of trust versus foundation and not. Now, I know that you could give me an answer for 2 hours in that, but just to give the listeners a better idea of specifically NHS England and your role, just however you want to lay it out for me there.
Okay, so I am a system-wide appointment. I have been appointed by the Department of Health, who are the government department who oversee health and social care in England, by NHS England, who are accountable for commissioning of health care services in England, and NHS Improvement, who are accountable for the regulation of all hospital and secondary care providers across England. So I sit at a national level across every part of the system. My role is to develop and deliver national strategies on information technology and informatics. So I hold the strategic direction. I lead on procurement and implementation of our nationally defined priorities. And I lead delivery and governance and assurance of all of our national programs. The piece that you allude to, I think, is in two directions. So delivery is done both through individual organisations. So each hospital in England is an independent statutory organisation. So each of them have a board, a chief executive, who are accountable to Parliament for the services they deliver. They operate under licence to deliver those services, and my role is to make sure that they do the things nationally that we want them to do with technology within the context of the licensing and the funding that they've got. NHS Digital are our national IT delivery partners, so they are a statutory national body whose accountability is really in four parts, I think. So one is around, they are our information analysis centre. They do all of our statistics, national statistics around healthcare. They run and operate all of our national platforms, like our NHS CHIME, summary care record, etc. They manage all of our cyber security services across the whole of the systems, including threat detection, threat monitoring, etc. And they also provide resource to support the deployment of the national programs that I'm accountable for. So my job is I commission NHS Digital to deliver things on behalf of the national system, either nationally or into local organisations, and I hold NHS Digital to account for their delivery. So that's kind of the system. You mentioned NHSX. NHSX is you will have got a small sense, I think, sitting in the US, that our national system is quite fragmented. So NHSX, from a digital perspective, is work that I'm leading with a colleague from the Department of Health about how do we bring the strategic policy delivery elements of the national system into one place. NHS Digital will continue to operate as a separate national body accountable for those things that I've just mentioned. So cyber, data, and live service, run, maintain. Hopefully that helps. I'm not sure it will help.
Yeah, no. It's a lot. And I just wanted to give people some idea of the structure and what's happening over there. Obviously, there's a lot of change, so
sure.
Very interesting. So looking forward to the conversation. Sri, you want to give us a little bit about your role at UC Irvine?
Sure. This is Sri Bharadwaj. Thanks, Anthony, for the opportunity. It's always good to talk to folks from Health System CIO. Held several leadership positions in the past, currently operating as Director of Information Services, basically responsibility for all of the application development, deployment, configuration, as well as the Chief Information Security Officer for UC Irvine Health. UC Irvine Health is part of the Regents of California universities based in California across multiple cities, and we have 5 health systems organizations that are coming together collectively to care for the patients of California. UCLA, UC San Diego, UC San Francisco, UCI, as well as UC Davis, which is in Sacramento. That is, we are working together extensively on various aspects, and one of the key areas we work together on is privacy and security. We have weekly meetings with the 5 CISOs, particularly to address any health system requirements around privacy and security on the one hand side. And then on the other hand side, within UCI, we work very closely with the compliance and privacy office on a regular basis. We have a executive compliance committee where the chief privacy officer and myself sit and report to the executive folks on what's really happening in the industry and what's going on within the organization.
All right, very good. Sri, let's stick with you here. Beyond the basics, talk about some of the data sharing initiatives that UC is involved with and the unique challenges that they may present to someone in your position.
UC is an academic medical center, so we are a teaching hospital. That means we do 2 other things other than caring for patients. We also discover new therapies, technologies, clinical trials, and so on, as well as teach our students who go through our schools of medicine, schools of nursing, pharmacy, population health, the way to practice medicine. So we have a dual responsibility apart from taking care of patients and running a hospital. That said, data becomes a key aspect of how we help people understand what's happening in and outside the environment. For example, we have a bunch of clinical trials that we run for our patients who provide us consent to use that information to improve the lives of other patients who are suffering from a specific disease or a condition. That's important to help not only move forward healthcare, but also to help our students discover and learn what's going on with specific conditions, number one. Number 2, we also use plenty of this data for research. We come up with the right algorithms to help with managing that data and helping define the next level treatment plans that will provide the best care for patients. That is the next big piece. So we have a huge research contingent that looks at this data across the board. The next thing is we are also a payer in some way, shape, or form. So we use data from a payment perspective, from a claims perspective, to understand what's happening to our patients. We have a large UC population, UC employee population that is taken care by all of our universities as well. So data is primary and key. Now, our responsibilities are not just distributing data willy-nilly, but going through a structured process of protecting that data in a way that it makes sense, particularly when you're looking at research. De-identification of data is a key common thing that we do. And we're looking at even how do we share this data in a de-identified form across the organizations that we work with. So all of us have what we would call a common data warehouse, and we put structures and processes together to understand what is happening within the data while it is de-identified from a patient perspective.
Very good. Will?
So we have, I guess, many of the same challenges that Sri has just talked about. Whilst we are a national system, we have the advantage of a single national common identifier for every patient that we treat across the whole of England. But we have, through reforms in 2012, we have very firmly separated commissioning and we put providers in pseudo competition with each other. So over the last couple of years, our kind of central policy has moved away from competition to one that's more cooperative, one that's more focused around localities and around how do we deliver the triple aim of improving health outcomes and efficiency. So we published very recently something we've called the long-term plan, which is completely focused about how do we reorient how we deliver the system. So one of the big challenges we've got is that from a legal perspective, every NHS institution is seen as being separate under the law, which means that sharing data requires the strictures of GDPR and common law to be met. And in the meantime, we are trying to implement infrastructure that enables us to build a single common normalized longitudinal record for every citizen that sits both regionally close to where they live, but also available nationally. And we see that being available for 5 purposes. So one is around direct care, making sure that all data about any individual is available to the clinician to action where they are. The second is to do case finding, to find those patients that I need to deal with, which may be around registries or identifying gaps in care. Third is around decision support, so running algorithms across all of the data to make sure that we can identify citizens that we absolutely want to deal with, or in real time to identify patients that have conditions that we need to deal with. Fourth is around basic population health analytics. And then fifthly, around research. So we are in the process of delivering what we're calling these local health and care record exemplars, which will cover populations of 3 to 5 million. Currently, 5 regions are developing end-to-end records, which will be a disaggregated data layer that will be normalized and held longitudinally across all data around care that they've received, but also around other social determinants of care. So at this stage, we've got 40% of England covered. By 2021, that data will flow in real time. It will be available for apps to consume for the consumer, but also for clinicians. And that data will be available for our research colleagues, both within academia, but also within research as well. By the end of 2024, we aim to have national coverage for that data, so every citizen in England being covered by a local health and care record. 2 specific challenges I think we've got. Clearly, there are technical challenges. We are trying to innovate and say we care deeply around the standards at the edge of these sharing communities. We care much less about the technical architectural details of how they are delivered locally. So there are technical issues. More importantly to us, there are governance issues, and that's both governance from a legal and process issue as a set of institutions, but more importantly about how we have the conversation with citizens about how and why we use their data and how we can give our citizens confidence that we are using their data appropriately and in ways that they would be comfortable with. So we see this as a sociological program much more than we see it as a technology program in the NHS.
Very good. Very good. Sri, Will was talking about apps and using data and things like that. One of the big things that has to come into play is working with other organizations and BAAs. So tell me your thoughts around that, around dealing with BAAs. Do you have sort of a template that applies to all of them, or is it very situational and specific to each entity you're going to sign a BAA with? Are there big changes between them from one to the next? What's your advice around working with third parties?
So specifically on BAAs, business associate agreements, for those folks who may not know what BAAs are agreements that we have with our third parties on how we exchange data between us and them in some way, shape, or form, and their accountability to manage the data. As folks on the call realize, we are a large, multi-system entity in a way, loosely coupled through our University of California Office of the President. So what we did a few years ago was to come up with a standard business associate agreement template and a format and documents vetted by our UCOP attorneys, and is what we subscribe to across all of the UCs. Very few amendments are typically done at the UC level individually, but we look at BAAs across the board. We also have a DS1, which is a security subscription amendment to that defines specifically something that we need to do with data. So our model, and very many other university systems adopt the same model, is that you have a single standard BAA with the least amount of edits that can go into the BAA, because it talks about limitations of liability when you have a breach. It talks about data classification. Talks about indemnification. You know, there are so many of these things that we need to address on an ongoing basis that we need to make sure the BAAs are sound. Apart from that, we also have an ongoing evaluation of third-party vendors that we do on a regular basis. It also depends on if they're offering and delivering the goods that they originally were supposed to be subscribed to. What are they doing when it happens? When they have an incident, what are the conditions and terms that we have with them? How do they have to report that back to us? So it's a pretty lengthy and pretty complicated process that we go through with third-party vendors, just to make sure that the UCs are covered, particularly from management of data.
Very good. All right, Will, in the U.S. here, we've got a lot of hospitals that work to integrate also or have some sort of interoperability with physician offices where the physicians are not employees. They're not owned practices, right? They're independent. They have the ability to practice at the hospital, and there's integration work there. So you have that dynamic. I know in the UK, I believe there are private providers that have contracted with the NHS to provide services to sort of supplement, the clinical resources of the system. So you do have trusts and other entities that are you want, I would imagine, some degree of data flow between the NHS entities and these private practices that are delivering services for the NHS. So from a security standpoint, first of all, you could tell me if I've totally botched that or have that at all correct, and then some security implications of working with these private entities.
So you have got it right. We do have a mixed economy. The private sector is a relatively small part of the overall health provision, but we do, individuals can have private health insurance and can opt to go private. We also do use private facilities to help us manage our capacity across the national system. From our perspective, I'm about to use a fatal word, which is it's relatively simple. And of course, it's not relatively simple, but regardless of whether you are a NHS provider or whether you are a private sector provider, the same regulatory requirements exist. So from a clinical standards and a clinical quality perspective, you're regulated by the Care Quality Commission, for example. From a data security perspective, the requirements are exactly the same. The legal standards that you're required to meet are the same, and each private sector organization needs to go through exactly the same accreditation process that each of our NHS providers would go through in order to access data and systems. We have a data security protection toolkit, which is a standard accreditation process that we use within the UK that every organization that is processing NHS data must complete and must achieve a certain benchmark level of standard before they're able to actually receive or utilize any of our data. So in some sense, the regulatory framework and the approach is exactly the same, regardless of what sector the vendor sits in.
Okay. Very good. Sri, I know you're quite close to regulatory issues, very involved. So what's the latest that you want the audience to know about?
Okay, lots happening just last week and in the past 6 months. Let me talk with what's happening in California, and then we take it from there. California passed California Consumer Privacy Act of 2018, came out sometime in summer of 2018, goes into effect in 2020, January. This is being looked at across the entire United States as a way to help manage privacy. There was a lot of apprehension in the healthcare community about the impact that it would have and what we would look at from an ongoing perspective. Luckily for us, there was a clarification that was issued sometime late last year where if there are companies subject to other privacy requirements in the federal Graham-Leach-Bliley, HIPAA, California Financial Information Privacy Act, there will be specific laws that will be, and if there are any conflicting requirements, then the existing the regulations will prevail. It's a good deal. That's a good thing. Specifically called out, clarified some clinical trials, healthcare provider information around the Confidential Medical Information Act as well. So that was useful. SB 1121 for folks who want to Google that and get some additional information. Just last week, we had a unveiling of legislation at the Senate level, talk about explicit consent from individuals before gathering and sharing health and genetic data was issued. It's sitting in the Senate right now. There's members of the House have passed a few legislations and looking at the national data privacy law that they are bringing together. A lot of steam building into this, just released last week. Apart from that, the various states, about 94 data privacy laws today are considered at the state level. Looking at one of the things that I would like to point out for folks is the North Carolina's 30-day breach notification that we're looking at, what impacts the healthcare providers specifically. Apart from that, of course, organizations such as ours deal with the GDPR that I think NHS deals with extensively, and I think that these are the things that are happening from a data privacy perspective. On the other hand side, there was an interoperability rule that was proposed during HIMSS, actually released on Monday by CMS and ONC, to talk about patients accessing their healthcare information. For folks who are curious, later today, there is actually a webinar that is being posted and talk about the proposal for interoperability and has a great impact on sharing of patient data across the board. Actually is being by CMS 2 p.m. to 3:30 p.m. Eastern Time for folks who are interested. So there's a lot happening from a regulatory perspective, a lot happening from a data privacy perspective, and we have various as part of the CHIME effort. Comments letter is due in a few weeks, and you're working on various sections to help all put together a response back to CMS and ONC.
Very good. Will, do you have the same dynamic over there in the UK where you have regulations coming out that are requiring interoperability and exchange of data and simultaneously or even in the same regulation requiring high levels of security? So it's that tug and that balance between, everyone telling you to share and everyone saying, but make sure you don't lose any of this data.
Probably not quite as active as it sounds like it is over in the US at this stage. I mean, we have been grappling with this for more than a decade. we've had various reviews, and there's a lady called Dame Fiona Caldecott who has done 2 or 3 reviews into this area. And interestingly, the policy here from a confidentiality perspective of clinical data is that yes, it is important to ensure, and there are a set of principles that we have around confidentiality, which is patients have a duty to expect their data to be confidential. In the last report that Dame Fiona did, she added a new principle in, which was around saying there is also a principle that says that sharing data is the right thing to do as well. So we need to protect it, but there should be an assumption for sharing. So I think that's the meta picture. Of course, we have also 2 other things. The GDPR has been mentioned. So we here do have a common law duty of confidentiality, and our common law is, law that's been enshrined for centuries. GDPR sharpens that up quite a lot, both in terms of what organizations are expected to do. So, for example, there are now principles of accountability where organizations are expected to be able to demonstrate the steps that they're taking to build in confidentiality, design confidentiality into the system, to be able to show the measures that they're taking to protect information, need to be able to demonstrate that the principles of the GDPR are being met, so that data is processed fairly and lawfully, with a legal basis, for limited purposes, be adequate, accurate, all of those issues. With 2 things also. One is if there is now a significant data breach, organizations have 72 hours to report that to the Information Commissioner's Office. And the fine for breaking the law is 20 million euros or 4% of an organization's global turnover. So teeth, both in terms of how quickly we need to fess up to what's happened, but also very hefty financial fines. So there is a great deal of awareness of what's going on. I think our challenge is getting the balance right between, as I say, protecting data and sharing data, because we know, and we have a campaign in England that says data saves lives. So sharing data because actually it can be life or death or better outcomes, making sure that you share data through the process.
Very good. You used the word principles, Will, in what you're talking about. And I was having a discussion recently at the HIMSS conference, moderating a panel, and we came across the idea of whether or not you're sort of open or closed as a CIO. Do you have that open approach where your number one principle is to empower your users and make sure they can do anything they want to do within reason? Or is your number one approach or focus to protect the system and then empower after that? So the question, Will, is actually, Sri, let's go to you. What is your philosophy? Do you have a philosophy of open versus closed?
So for us, I would say we do both, actually. We have a structured governance process that outlines how we want to operate and how we manage risk at the highest level. That includes data privacy and security risk. On the other hand side, we have a need to help students flourish and figure out what they need to do in order to get the best learning possible. So we have that level of openness that allows the students to kind of do what they need to do to learn. So it's both. And so when I look at running a health system, managing a health system, privacy and security aspect of it is more governed by our executive compliance committee, our compliance, risk, information security, and privacy committee, where we pull all the time information from various happenings within the organization and provide some feedback around that. apart from communicating with leadership. That's one thing. On the other hand side, we also help students understand what is private, what is data, how do they keep it safe in a way that makes sense for them as well as for our patients. So we do both on our end, and neither of them works if you're just doing more of one or the other, purely because of our academic medical center philosophy.
Will, are you going to tell me you do both too, or are you going to give me one answer? Just kidding.
So I think we try to take a risk-based approach, and certainly the conversations that we have from the center, from the national bodies down to local bodies, is that organizational boards need to understand what their risk profile is, where are the risks in their organization. They need to understand what their risk appetite is, because there is no risk-free route to do this. And they then need to put in the systemic and systematic controls to deliver it. So I think it is a balance, which is a very British thing to say, isn't it? Because locking everything down so that a clinician can't do their job is probably as dangerous as letting a clinician do whatever they want with completely open systems. And actually, we need to rely on each individual security manager in each individual organization to take rational and appropriate decisions based on where they find themselves and what they believe their key risks to be.
All right. So it's got to be a balance. I think that's the consensus. All right. This is a fun question, and I'm sure you both appreciate this. Being in the role of protecting data and preventing breaches it's a tough job, right? You have to put in security measures to make sure nothing gets breached, nothing gets lost, but everyone's happy and can do whatever they want in a very easy and seamless way. And breaches can be very bad for one's career prospects. So it's a tough job. And so the question is, how do you deal with that? Is it sort of like, especially for you, Sri, being the CISO, is it like being the dentist that everyone needs but they don't particularly love because they make their lives a little less pleasant? How do you deal with the role? And is it a tough role in terms of somewhat being thankless?
Yes, it is. It's worse than going to the dentist, actually. So here is the situation, right? I mean, we are put in a spot where we are managing risk for the organization, not just data, but actually the entire risk that is happening within the organization. Keeping my boss out of the paper is my primary job, right? So the goal is we try to ensure we can allow folks to operate in a collegial manner while understanding the fact that they have data in their hands that basically is not theirs but the patient's in a way, shape, or form. So what we've done is, we have a research capability, but we have a structured process around that. We built security around it that does not impede researchers, impede our clinicians to pull the data from the EMR. That's one thing. The second thing is where we know that there is plenty of patient data that is open and available, we put in the right level of controls in place using a role-based access control mechanism, for example, to manage how people get access to it, and the right people have access to the right data only, right? So we do a combination of both, and sometimes we get pushed down a path saying, hey, I want this data because I'm doing X, Y, or Z, and we go, okay, do we have the right information, right approvals, and then we take it. There is a bit of a slowdown. Let's not say that it's not there, but at the same time, speedy execution is one of the things that we are proud of. So we have a way to manage risk, manage the requirements. And the best part we found is that we have now helped teach our population of folks what's the right thing to do? So it talks about education. It talks about how to help them understand what they should be doing right rather than slapping their fingers when they do something wrong.
Very good. Will, your thoughts on that, managing that role and keeping your sanity?
I would agree with everything that Sri said. I mean, it seems to me that there are two real challenges. One is about how do we have an open conversation with those people at the security controls that we're putting in place of impact, because there is an important communication and focusing on why we are doing the things that we are doing and the rationale and why this is a clinical safety issue to ensure that data is protected. So I think communication is really important. We also have a second thing that we think about, and we don't do as well as we should do in the UK, in part because we probably don't have the level of fundamental infrastructure investment that we require in the technologies, but we should design security in from the start and actually make doing the right thing the easiest thing to do around data security, so that it shouldn't be a case of leaving computers logged on because it's easier than having to log on every time you move around the ward. We should provide facilities that actually makes it possible for the clinician's workflow to be protected by the right system controls. So I think those two, but of the two, communication and education is the most important.
All right, very good. We have an audience question that I want to get in front of you, gentlemen. So, Sri, let's start with you. Do you think we need to prepare for a time when patients will need to approve the release of even de-identified data? Sri, are you still thinking? Will, you there?
Sri obviously did the thing that I should have done, which was run away when the questions were being asked.
He's faking not being there. Will, why don't you grab that? Do you think we'll need to prepare for a time when patients will need to approve the release of even de-identified data?
So in an American context, I don't know. The area that we're grappling about is around the issue of data ownership. At the minute, the data that we hold within our organization systems is effectively owned by the NHS. There are opportunities to move to a co-ownership model where the data is jointly owned between the patient and the system. That gives us quite a lot of opportunities to give citizens more control over what data and how they share that data. So we want to see citizens much more deeply engaged around the issues of their data, give them much more visibility of the data that we hold about them, and to be much more transparent about how their data is used, both for their own care, for the care of others, and for research. As far as anonymized or de-identified data goes, I'm not sure. At this stage, we are taking the view that once data is anonymized, it's no longer personal health data, although we are beginning to look at issues like how do we make synthetic data, for example, that means we get all of the benefits of the identified data for research purposes without actually having to use an individual's anonymized data as part of that process.
All right, let me get one more question in front of you, Will. Most people in having anything to do with information security, at least over here in the U.S., will say it's not a question of if, it's a question of when. And I've often heard CIOs at conferences say, I guarantee you my system is being hacked right now. So my question to you is, as a CIO, how do you prepare your boss, the higher-ups in your organization for what many think is inevitable? Is there messaging? This is sort of advice to your fellow executives. how best to prepare those you report to for what many say will happen.
Yeah, we were quite fortunate that 2 years ago we had a small issue with WannaCry that took time. A number of organizations, in fact, I wrote a lessons learned review for the Department of Health about it. And the opportunity that gave us was, one, to reinforce how important technology, data, and systems are now to the operation of our hospitals and to our health systems. So there's no longer a sense in which it's unimportant. It's core to how we deliver healthcare today. Second, it's very well demonstrated that actually we are vulnerable and the implications of that vulnerability. So the way that we've addressed it is to reinforce the message that the only thing that we can guarantee is that there will be another breach or there will be another cyber attack, and at some point it will be successful. And I went to the Public Accounts Committee over here, which is a committee of Parliament, and I said to the Public Accounts Committee that I can guarantee that there will be another breach of data within the NHS. The only thing I can tell them is when and how serious it is, but it is a 100% guarantee. And they, to be fair, understood that. So that's an important message. The second thing that we push very hard in the UK is this is not a technology risk. The board should not see this as a tech thing or as a we have something over here called the National Cyber Security Centre, so GCHQ MI5 type organisation, you know, who will talk about state actors and will talk about kind of, you know, the kind of threat. Actually, yes, all of that is true, but this is fundamentally a business risk, and it should be treated as a business risk in the way they treat every other risk to their business, which is about discussing it, talking about it around the board table, making sure they understand the vulnerabilities, what the remediations are, to make sure they've got business continuity in place, and to make sure that they are prepared, rather than pushing it back into a technology space where it becomes a technologist's problem rather than the CEO's problem. Because fundamentally, it's the CEO's problem. I'm there to help, but they've got to own it. They are the people that will be in front of Parliament or on the front page of the newspaper when it all goes wrong. So treat it as a business problem, accept that we can't get 100% guarantee, but manage it and take the best advice.
Very good, Sri. I think
Anthony,
we're going to give you. Yeah, I saw you, buddy. Thanks for jumping back on. I think we'll give you the last word. The question was about preparing C-suite executives and the board for the inevitable breach. Is that a tough message coming from the CISO? Is that something they don't want to hear from you? That something is going to happen?
It's actually not a CISO message. It's a CEO message. The reason why I say that is because managing data, managing risk is the board obligation, is a board responsibility. And we made that a board obligation responsibility. I keep telling folks we are never secure, 100%. We probably are attacked every minute. We just don't know that. There is always a breach happening. It's just that we don't know that the breach is happening. For every organization, not just us. That's the nation. That's the way we live in. So the goal is to try to figure out how to manage that communication upward, and more importantly, how to manage the communication downward as well. So what we've told folks is that you are as strong as the weakest link. So every RN, every registration person in the front desk, every physician, every clinician, every researcher, every student who handles patient data is responsible for it. And if and when an incident occurs, we have processes, policies, plans, all of that in place, obviously, including a communication methodology and structure on how we communicate to folks. But at the same time, it's not about that piece. It's about how do you engage, how do you work with the people at the grassroots in order to get that information out there so they actually become the fence, and you are not creating technology fences to manage data.
Excellent, excellent. Well, that's about all we had time for today. When you close out your WebEx window, you'll be taken to a post-event survey. If you could answer that, we'd appreciate it. Regarding the CHIME CHCIO certification, attending our webinars gets you 1 CEU. You'll receive an email when our archive recording of this event has been posted to our YouTube channel. You can reach out to Nancy Wilcox from our team if you'd like us to produce a webinar on the topic of your choice, and you can go to our website to view our upcoming schedule. So with that, I want to thank very much Will Smart and Sri Bharadwaj, and I want to thank you, all our attendees, for coming and continually attending our events. We appreciate it. And with that, everybody have a wonderful day. Thank you.